Okay, let's start. People are now connecting. They can join us during the meeting. Okay, good morning, afternoon, or evening, depending on your time zones. And thank you for being here. This is the first webinar of the year for our Society for Systems and Complexity Science for Health. The theme is that of mental health and primary care. I will say that this is a sort of a hot issue because there are so many projects and models that have been and are currently tested and developed all around the world. So we think that it's necessary to confront each other about what could be best practices in this so important area. And the topic is important since we know that a high percentage of GPs consultations pertains to mental health, being it explicitly or not. And but I would say that in a systemic and in a biopsychosocial framework, we could say that there is a mutual influence between mental health and medical complaints in almost every condition. And so that's why the topic is so important to develop good practices that could be beneficial for the health of the community and also in terms of cost effectiveness. So on a practical level, we have two presenters today, and we will have time for some questions at the end of both the presentations. It's quite a big audience, so I would prefer if we could use the chat for the questions. And so I give the floor to the first of our presenter, which is Alexander Blount, Emeritus Professor of Family Medicine at the University of Massachusetts Medical School and President of Integrated Primary Care Incorporated. His presentation will be about first and second order patient-centered approaches in US primary health care. So please, Alexander, thank you.
Thank you, Francesca. I'm honored to be here and delighted to be here. I want to start with a little bit of history of the idea of patient-centered care in the US. Then go to schema in systems studies that many will be familiar with, and then come back to try and outline ways of going forward to use the insight that I hope you will find. The idea of patient-centered care has been growing for a while, but the place where it came forward, I guess, most strongly was in 2001. The Institute of Medicine, now called the Academy of Medicine of the US, issued a scathing report called Crossing the Quality Chasm. It was a book-length report identifying problems in the US health system, and it called for a new system of healthcare for the 21st century. The problems of quality were summarized as overuse, underuse, and misuse of care. Staggering levels of harm, that's their word, staggering levels of harm and unnecessary cost were attributed to these problems. Primary care was seen as the best possible laboratory for developing solutions. And so the authors called for a reorganization of primary care that would improve access, make the routines and processes of care more understandable to patients, and make it more evidence-based, more efficient, and better coordinated. To do this, they offered 10 guiding rules for better primary care and better healthcare generally. These rules fall into two general groups. One we might call the medical home rules, which are about how to run the practice of primary care. And the other we might call the patient-centered rules, which are about the relationship between patients and their health professionals, particularly their physicians. For what I'm calling the first order of these rules, the medical home rules, they call for evidence-based decision-making. Safety is a property of the system. No longer are we counting on all humans to never make a mistake in order for patients to be safe. The anticipation of needs of patients rather than only responding to needs that patients come and express. That there would be continuous decrease in waste, hence improvement in cost and quality over the course of the practice, driven by a much more sophisticated data system. And there would be cooperation among clinicians, that no longer would clinicians live in specialty silos and instead would share information that as it pertained to a patient's health. The second group, what I'm calling the patient-centered rules, and what I'm going to claim are second order rules, call for care based on continuous healing relationships. That means that care goes on over time, and to the degree possible, there's continuity of care and relationship. That care would be customized to conform to patient needs, but also to patient values. That the patient is the source of control in the design of their own care, that therefore they be given adequate information so they can actively participate in decisions about their care. That there would be shared knowledge and free flow of information. Patients should have unfettered access, that's their word, to their own medical information and to clinical knowledge about their conditions. And finally, that there would be transparency beyond just a patient's medical information, but transparency in relation to broader elements in healthcare, such as stakeholders, effectiveness of different treatments, costs, and the other elements that are part of the knowledge of professionals, but not necessarily of patients. So these two groups, the patient-centered rules and the medical home rules, were combined and were systematized into what got called the patient-centered medical home. And this model was incentivized for primary care practices. Some practices are paid more for living up to the elements of the model. Others were given extra funds in order to be able to do the data management that is required. And there was a national demonstration project for the patient-centered medical home. It involved a great number of primary care practices. And of course, there was an evaluation. The evaluation came back 4 years or so later. And what the evaluators found was that the medical home rules or guidance had, in general, been achieved. That it was not an easy process, that the doctors didn't necessarily like the change, and the patients didn't necessarily like the change, as they were going through it, but that 4 years on, most of the practices had been able to make the changes that were prescribed in the medical home aspect of the model. But the patient-centered aspect of the model showed very little progress at all. The whole aspect of the patient as the source of control in their own care not only hadn't been achieved, very little progress had been made in that direction. The evaluators really, in a way that they had not expected to, called for the need that doctors needed new mental models of care. They needed to understand the contingencies of relationship that constitute the doctor-patient relationship differently. And the same would be true for patients. This is a dramatic finding. Let me take you now to the schema that I'm using to help organize the way to think about this finding. And I want to go to Gregory Bateson's concepts of first and second order learning and the sinking of premises in complex systems. Bateson said that complex systems that function successfully within an environment, that is, systems that could be said to learn, which would include all living systems, have to be able to match the flexibility of the system with those aspects of the environment that are changeable. That in order for the system to stay viable, it needs to be able to accommodate its environment, the changes in the environment, and that no system has an infinite budget of flexibility. In order to remain viable, it has also elements of stability, elements that are consistent across time. And so to the degree that the system is viable, it will make generalizations, not conscious necessarily, but will inhabit generalizations about what is consistent in the environment. And those premises will be sunk. They will be less accessible. They will not necessarily be changeable. The process of sinking of premises, as we look at human function, is discernible up and down the levels of complexity of our interaction with our environments. From the most basic changes in neural alerting to our most complex organizations of interaction and meaning. At the level of human to human interaction, we can describe first order change at the level of flexibility, as change in the response in a given situation within a constant experience of the available set of responses. Learning one. Time A, within the experience, the contingencies of relationship of a teacher and a student. At time A, the teacher says, "Johnny, what's the capital of North Dakota?" And Johnny says, "I don't know." And at time B, same contingencies, teacher, student. The teacher says, "Johnny, what is the capital of North Dakota?" And Johnny says, "Bismarck." Bateson calls the experience of the available set of responses the contingencies of relationship in the context. These contingencies of relationship are consistent set of expectations, not necessarily conscious, developed usually over multiple iterations. Communication or cueing about the expectations of what set of contingencies is in play is done at an abstract level in perceptions in the context, in tone of voice, in body movement, even in smell. It can't be controlled consciously, and it will be perceived both consciously and unconsciously. This is the place where our distinctions between mind and body really no longer hold up. We can put these contingencies into words, of course. We could say in one situation, is this a chat about our mutual field of study, or is it an interview for a position? Or maybe sitting in another situation, one might ask oneself, is this a nice cup of coffee, or is she breaking up with me? It's usually not discussed between people because when you initiate the discussion of the contingencies, it changes the contingencies of relationship. The determination of contingencies of relationship is a crucial task, however, for us to feel viable or comfortable or settled in a social situation. Second order change, therefore, Bateson's learning too, is a change in the experience of the contingencies of relationship, and therefore in the possible choices of response in a constant setting. It is this level of change that the patient-centered rules, the rules about the contingencies of relationship between the patient and the health professional, call for. And it's the same change that is made through multiple instances of interaction, not simply because one decides to experience contingencies differently. So second order change is harder. It comes from multiple iterations, but it's proving to be necessary, particularly in response to one substantial group of people who have been identified because of another one of the medical home rules, and that is the rule to reduce waste, to save cost. These folks were identified because of the high cost of their care. The health system tends to call these people complex patients. This is a name for the experience of the health system in trying to meet their needs and reduce costs. Others have called them the overserviced and underserved, since they come back a great deal using emergency and inpatient services, but don't get their needs met. As a group, they tend to have one or more chronic illnesses, to have mental health challenges, often with substance use concerns. They tend not to follow their doctor's instructions and commonly are suspicious of their doctor's motives and often resentful of the doctor's chastisements about how they take care of themselves. These complex patients are statistically the same group that one might call disadvantaged patients. That's people with low incomes, people with low educational attainment, and high background stress from daily experience of racism or bias. Finally, this same group of people has extremely high rates of trauma in their histories. So second order change takes longer, but for this group, we're learning what works. The evidence about complex patients or disadvantaged patients or patients who have experienced trauma finds that they engage and respond best when the health professional shows a commitment to helping them become a partner in their own care. When a strength-based approach is taken, and when care is transparent. In other words, the population of patients that our system is failing to serve requires the approach outlined in the patient-centered rules of the Institute of Medicine, a change in the experience of the contingencies of relationship in medical care for both doctors and patients. Finally, the evidence finds that to successfully meet the needs of these patients and to help have the system be responsive to the broad array of needs they bring requires a team approach. In many cases, patients are coping with chronic illness that can't really be addressed until mental health or substance use issues have been addressed. Integrating a team member who can address these issues, who's skilled in helping with health behavior change as well, is part of a basic approach to successful treatment. The advantage of conceptualizing this group of patients in the full complexity that they present is that it begins to explain the phenomenon that when one works in the area of their medical, mental health, or substance use, when one area of medical, mental health, or substance use begins to improve, quite commonly, other areas show improvement as well. For these people, multiple treatments for multiple diagnoses is not as good a model of care as a fully integrated team approach to one complex biopsychosocial pattern. When we get it right with these people, it is very rewarding. And we have exemplars in our system that are getting it right. In these organizations, in these primary care practices, what you see are a change in the assumptions about the role of the team. The team has flexible leadership, regularly shared information, new expertise and new services added. It takes a fundamental strength-based approach to care. Change in the assumptions about treatment and care relationship. In these exemplar practices, patients are seen as the guiding force, if anything, the champion of their own healing journey. That primary care behavioral health, that includes mental health, substance use, and chronic illness support, is conceived of as a basic primary care service rather than a specialty mental health service. That learning and teaching are core tasks in these primary care settings. They realize that the attitudes and the knowledge that it takes to do this work in within this second order change, they wouldn't use that term, I use that term, require a different approach than people come out of their graduate training with. And so the training and learning is ongoing. For organizations who are at the start of such a journey, the development of each practice or group of practices tends to follow a similar stage as the field as a whole. The basic learning and changing takes the time that it takes, and it takes the experience that it takes. The benefits of this sort of second order change have been well documented. Improved job satisfaction and lower attrition for the primary care workforce as a whole. And attrition in the primary care workforce is a terrible problem in the US. Improved patient satisfaction with care. Improved adherence to medical regimens and improved health outcomes. Often, the exemplar sites serving very stressed populations have better health outcomes than more usual sites serving much more advantaged patients. And lower costs of care from reduced use of specialty and emergency and inpatient services. So how do you get there? What are the steps that could be taken day to day? What are the iterative, multiply multiple kinds of experiences that gradually build the generalizations involved in this second order change that the Institute of Medicine called for. And I'm offering a mnemonic to help bring those together and make them able to be remembered. I call it the TEAM way, T-E-A-M. T is for transparent. E is for empowering. A is for activating. And M is for mutual. Transparent is now part of the in statute in the US. Patients are now required to have access to their medical information, electronic access, not going and having to get copies and sign papers. They should be able to see all the text about them in their medical record. That to do this kind of access can require professionals to learn to adapt professional speak a bit, because professional language, while it may not be judgmental by the use of the professional, can feel very judgmental to patients. So, for instance, a note that says, this obese 34-year-old female with type 2 diabetes might be changed to say, Mary Smith is 34 years old. She struggles to manage her type 2 diabetes and control her weight. This little bit of change, though, makes for a great deal of transparency that patients have been shown to appreciate and has been shown to build trust between patients and their physicians. If one is used to writing this way, it takes very little additional skill to talk this way, meaning that most of the conversations about patients that we have with our colleagues in the hall could be in the room with the patients. And when the patient is there, when the information is being exchanged about them and hears it and can contribute to it, the adherence and the engagement with the new team member goes up substantially. Empowering is a term originally out of trauma-informed care. Patients are caught in the act, if you will, of doing their health care correctly to the degree that it's possible. Sometimes in a pattern of not very positive health behaviors, there'll be an exception. And focusing on the exception and on the dynamics of the exception, studying the times of sobriety, the times when their hemoglobin A1C was lower, the small improvements in activity levels, noticing the problems that didn't happen, the list of cigarettes not smoked, drinks not taken, the times when a person came to the appointment even though they really didn't feel like it. This tends to build self-efficacy and to build engagement with patients who tend to expect to feel, if anything, marginalized in their care. Then there's activation, that by using these empowering observations to make attributions about patients, attributions about their care, their commitment to their health for their sake or the sake of their family members. Those attributions gradually support and hold more adaptive health behaviors. And when attributions are used regularly in a relationship, gradually those become part of the experience of the contingencies of relationship. What starts as perhaps a a difficult search to find an attribution gradually becomes more and more natural and more supported by patients and doctors' experience. And the last is mutual. And mutual is having a process by which the care plan of the patient can be explicitly mutually developed. The patient-centered care plan is one way of doing that, and it provides a way for those aspects about the patient that the patient is most expert in, what their own values, the people that are valuable, that they want to know about their care, the reasons, the aspects of themselves they want their care team to know about them, be part of the care plan that also has the plan from the team members on the healthcare team, and that this one single plan follow the patient around the healthcare system so that everyone uses the plan every new provider is oriented using this plan. So what I hope we've shown here is, I'm going to share a screen so that if you want these slides, which are in more detail than you're seeing here. So what I'm hoping we've found is that by using a more our fundamental training in systems and in the way of systems operate, we can understand better why aspects of our health system go quickly and why others are evolutionary in time, and that we can specify actions to be taken day to day in our exchange with patients that build the experience of the contingencies of relationship that are self-sustaining in exemplary sites. And I will, at the bottom, you see my email address. If you would like the slides, I'd be happy to send them to you. That at the top is the book that is the evidence and the outline of what I've been talking about today, the patient-centered primary care, and the website, teamtelemed.net, of one patient visit using these general ideas. And then below that is a book on integrated primary care, bringing behavioral health people, mental health people into primary care, and a website, integratedprimarycare.com, with a great deal more information on that. And I will now pass this back to Francesco and Mira.
Thank you so much. Thank you so much, Alexander, for your impressive presentation. I'm also happy that you have emphasized the relevance of Gregory Bates on epistemology, that is often overlooked in the academic world, I think. And so thank you so much for your presentation. And another expert of Gregory Bateson is our next presenter, which is Mira Mogina, psychiatrist and psychotherapist, director and lecturer at the Sigmund Freud University branch in Ljubljana. He is presenting on challenges of mental health primary care, the Slovenian experiences in the European context. Please, Miran, thank you.
Thank you, Francisco. I would like to start with some slides and then go off and talk more freely. But for the start, I will share screen. I hope will go. Do you see the
Yes.
challenges? And it goes on, or it shifts. Do you see the Slovenia slide now or not?
No, only the first one, Miran.
Okay, I must go again. One moment. One moment.
Yes.
And now, is the second slide or not? Slovenia, or is the first only?
Yes.
It shifts or not? Do you
The
see?
first one.
The
The first one. We see the first one.
Okay. One moment again. And now, if I go
Yes.
back, now you see the shifting?
We see Ljubljana, and then
Slovenia now?
yes, yes, yes.
Okay, it's shifting now. Okay, thank you, Francesca. I first would like to introduce the beautiful part of my lecture. This is about Slovenia, which is a small country, half of Switzerland, 2 million inhabitants. We have become independent in 91 after communist period, and we are a part of European Union from 2004. Now you see the capital, Ljubljana, a little bit?
Yes.
Yes, nice.
Yes.
So Ljubljana has become quite popular as a tourist destination. It's a nice town, but also Slovenian landscape, small country, but if you travel 50 or 100 kilometers, you can see this such landscape. This is a very known Blount, and we have mountains and rivers and Alps and plains and seaside, vineyards, castles, lakes, and forests are 60% of our territory. So this is for a sweet beginning, because the problems that I will talk are quite disturbing, I think, for everyday practice in Slovenia. To be a medicine doctor, psychiatrist, or psychotherapist, a combination of these two professions, both, it's not an easy time to work and live. The problems I would like to open is why, when we know so much, also your lecture, Alexander, was so nice with how this patient-centered approach can be realized. We know a lot about theoretical background, but when we look what is happening in Slovenia, and when I look also in Austria or Italy or other countries in Europe, this biomedical model is prevailing. We know that biopsychosocial model is much more useful for mental health field, but we have this medicalization growing. Why the drug consumption is rising? Why the trust to doctors is decreasing? Why doctors don't have enough time for patients? And why most people want quick fix? They are not ready to change their habits. They prefer to take drugs, medicines, and hope this will make them happier and more successful. When I'm writing and finishing slowly a book about the topic about the great psychotherapy debate. And in the field of psychotherapy, this debate is going on more than 100 years. And it is the debate about why this biomedical model prevails and why this old categorical diagnostics is still in the center of how mental health system is functioning, why the context of clients and patients living is so neglected, why there is so much emphasis on techniques and methods of healing and not on therapeutic relationship and common factors. Like also Alexander, you emphasized how in the patient-centered approach, relationship between helper and the client is crucial. Uh, I'm trying to, in Slovenia, we have a long battle, 25 years, so to say, to get a psychotherapy law in which this law should promote the idea and regulation of psychotherapy as an autonomous profession and discipline. And in this battle, the same goes on, this big psychotherapy debate. There is a big resistance among medicine doctors, psychiatrists, and clinical psychologists against this idea that psychotherapists could be autonomous profession and can join in the mental health fields to work together. What is the basic assumption of medical model is this specificity, that specific diagnosis will result in specific intervention. But is it really possible like to work like this in the mental field? The problems are already with diagnostics, as we know. This DSM-5 is not useful, and it still is used, and also international classification of diseases, the same thing, categorical diagnostics, and we don't know really why this is going on and on and on. And we have now a lot of data how antidepressants are not so helpful, and other pharmaceutics, antipsychotics, benzodiazepines, and so on. There is a lot of evidence that these medicines are not only less helpful than we hope, but also can be much more dangerous. And we know for a lot of time we talk with Francesco and Alexander when we were preparing for this meeting about Michael and Enid Balint, about Balint groups. Alexander was in Balint groups, I was in Balint groups. We all learned about how the most potent medicine is doctor. And also, again and again, research shows how placebo is connected to therapeutic relationship. But instead of improving this, at least in Slovenia, we can see during last 20, 30 years that all patients' evaluations of this healthcare system shows greater and greater dissatisfaction with relationships between personnel, medicine doctors, nurses, and patients. This is rising, this dissatisfaction. I'm working, as Francesco told, in Sigmund Freud University landscape. This project started in 2005. And in this university, we have four faculties for psychotherapy, for psychology, medicine, and law. The big difference is that since 2005, our project is offering direct psychotherapy study after secondary school. This is something new also for Slovenia. We have several branches, also in Milano, Berlin, Paris, Linz, and Vienna. In Ljubljana, we teach psychotherapy and psychology. We teach different psychotherapy school, and we have also outpatient clinic. In this moment, 650 clients are included in this clinic. 150 therapists work under supervision, students. We have 60 supervisors, and we have also child and adolescent unit. This is important because we are trying to be part of this primary health, mental health care system. But it's very difficult. We can also only work for those who pay alone, the clients. We don't get any support from public funds. So this is one of the reasons why we would like to become more involved or more integrated in the healthcare system. We have now a very marginal social position as a psychotherapist. We don't have a registered profession, we don't have law. At the moment, around 1,000 psychotherapists work in this private sector, only around 150 full-time, and we would need at least 2,000 psychotherapists at the moment. But there is hope. We are connected in the umbrella organization, and we are trying to get psychotherapy as an autonomous profession and to be included in the legal system. So our endeavors for the academization of training is helping. I hope that in the future we will get this law. It is promised to become accepted in the parliament this year. If now I go to the description slowly to the healthcare system of Slovenia, we have these three levels: primary, with primary health centers and pharmacies. We have secondary specialist, ambulatory outpatient and hospital inpatient care, and tertiary level clinics, clinical institutes, and departments. There was a resolution on the National Healthcare Plan from 2016 to 2025, called Together for a Healthy Society. And now it's in the public debate, the new plan for the new 10-year period. So there is a lot of now confrontations and discussions about how to improve the situation. If we look to all publications, I was looking at during last days, these fresh ones that appeared in 2023 about what is the situation of healthcare system in Slovenia. It's interesting that in all this publication, it is written how well this system functions and how well it is geographically well distributed. We have many, a rich network. There is a combination of funding between municipalities and Ministry of Health. And doctors in primary care are gatekeepers. Our community health centers, nice buildings, and they offer medical emergency. You can get free family doctors care, pediatrician, dentist. You can be diagnosed. You can get diagnostic from the basic laboratory. These are the main services that are promised to be offered. You see, it looks quite nice. And we have a beautiful World Health Organization uh, recommendations how we should be concentrated on prevention, early intervention, treatment, recovery, a beautiful, beautiful idea. And for example, in the report of World Health Organization about Slovenia, you see we have integrated person-centered primary health that produces very good results. This is the direct citation from this World Health Organization report, how Slovenia was recognized as a notable exception regarding developing effective primary care systems. We have an impressive primary care which performs very well. This could be partly attributed also to the successful integration and so on and so on and on. We are the champions. We are the champions, at least in these beautiful, nice publications. And then if you look to the comparison about OECD, 38 members, Slovenia is excellent. It's very good in this. But in this report, there is a one sentence, two sentences that Slovenia system is showing signs of strain that threaten the sustainability of our achievements. There is much to be learned from its accomplishments and community-based and so on. So there is a warning, and this warning during COVID times, the COVID somehow opened more clear insight about the problems we have. So we are known with high suicidal number attempts. So this has gone even higher. Alcohol abuse, violence in the families, and mental health problems of children and adolescents have risen for 20%, especially lower class families. The reality of Slovenian healthcare system and primary healthcare system at the moment during last years, also after COVID, is quite different from these beautiful publications. I will try to ask why this contradiction between these beautiful descriptions, beautiful publications, and the reality. You see, Slovenia, as I told you, 2 million people. At the moment, 140,000 Slovenian citizens are without family doctors. This has not happened in the history of Slovenian public healthcare system since Second World War. This is something new. Then the corruption is rising. We have no quality control. Officially, there is an evidence that our doctors made 50 mistakes per year. this could one interpret as a beautiful, wow, you are very good, you're champions. For example, Denmark has 200,000 officially reported mistakes of doctor per year. In reality, we don't have quality control. There was a big shame now because during in the last month, the two patients were there was a mess, and one patient who was healthy was diagnosed that he has a cancer in his stomach, so his stomach was removed. And the other patient who was uh, diagnosed in a different way, it was opposite. So what happened? The samples of gastro testing was has changed. So the wrong patient was operated. So this was a big mess also in the news. So, and such things are more and more happening, and we are not learning anything about it because we don't have any successful quality control. During last month, the longest doctor strike in Slovenian history, it started in 15th of January, and it's still on. The government and the doctors cannot find the same language. The main problem is that doctors want more money, more money. They are not so, their salaries are not so bad, but this economic kind of thinking has grown. Waiting times. If you want to get a psychiatrist or clinical psychologist or psychotherapy, you must wait 1 to 5 years. So we can say delayed help is help denied. You cannot get efficient psychiatry, clinical psychologist, or psychotherapy help at the moment. We had two important mental health acts. One was in 2008, one was in 2018 for the period of 10 years. The basic idea is very nice. This World Health Organization pyramid framework, where you see you have self-care at the bottom, and then you have this specialized stationary treatment at top, and the money should flow, that the most public money should go to the bottom of the pyramid and the least to the top. But if you look how the money is running in Slovenia, it's just opposite. The most money is given to hospitals, least to prevention. This is also a beautiful program for this period, 10 years period. Everything is, the strategic goals are defined, for example, alcohol problems, prevention of suicide, and also improvement in the mental health field. But if you look how much money is spent for these programs, it goes down. So when I look, I promise to say something about European context in comparison, what is happening in Slovenia. In 2016, Belgian clinical psychologist Paul Verhege wrote about the case of Mark Desmet, Flemish palliative doctor, who wrote an open letter to all Belgian people, and there were 4 points he was emphasizing that he is experiencing in the hospital where he works continual structural improvements with less and less quality, that There is more and more control over staff, and everything is satisfied on the altar of measurability, and the real patient care disappears. There is less and less focus on work itself and more administration, management, control. And it was a very humorous remark. He said, um, the healthcare system would work very good without patients. And I would add that my experience in the university field is that also uh, this education system would work much better without students and without pupils. So what is happening? We don't have time anymore and resources less and less to have enough time and to build these quality relationships with our patients and our students. So the disgusting contradiction is that we are constantly being forced to cut costs, while at the same time we see ever larger sums of money being spent on things that serve no purpose. It's interesting that these 4 points would be are very well suited also for the situation in Slovenia. Verkege also is describing cancers that are ravaging healthcare system. Everything is quantified in numbers, and we forgot that, for example, the quality of therapeutic relationship is very difficult to be caught in numbers. There is an explosion of rules and regulations, this hyper regulation, uh, and there is a big pressure to be more and more efficient, and with this pressure, the quality is falling down. So the Slovenian quality uh, is now uh, shown in these beautiful publications, but I see it less and less in my everyday life. For example, more and more uh, adolescents and children are coming to our outpatient clinic uh, with 4 or 5 medications. They have 2 antidepressants, 1 antipsychotic medication. They have medication for stabilizing their emotions and so on. It's incredible how this over prescribing of drugs spread during last 20 years. I'm now 40 years working in this field, and if I would prescribe 30 or 40 years ago when I started my career as a psychiatrist, so many drugs to one client, I would be criticized a lot. But now everything is now possible. You can give people 3, 4, 5 different psychotropic drugs. We have also the problems with the fragmentation of services. We have a lot and different NGOs, public services that should work together, but the fragmentation is rising. For example, I had a case now working on it I was a part of this story because one father killed um, um, his wife, and the 6 children remained without mother, and the father is now in the prison. And we had to take care for these 6 children. They were situated in different families, in homes. So, and when we counted the services that were involved in this case, we came to 46. 46. And the coordination among these was not very good. So this medicalization of mental health care, this prevalence of biomedical model has gone to the sky. I would like to close this presentation of slides and then to discuss and to say something for closing. In 2015, the World Health Organization sent experts to Slovenia to evaluate the mental health care system, and they saw many things to make better. They came again in 2020, and unfortunately, they didn't see the most important improvements. We have now established around 25 new centers for mental health on the primary level for adults and for children, but there is a problem with staff. There are not enough people who could work there. And it's interesting that in these around 50 new centers, there is no place for psychotherapists, and psychotherapy is offered only on the paper. Most psychotherapy sessions you can get, for example, is 8, and in the distance too long in between sessions. So many problems, and the situation is not optimistic. We can say that we have a situation of rapid disintegration of healthcare system and mental healthcare system, which is happening despite these good documents that we have, regulation that should help us, and a lot of money spent, but not efficiently. So I'm very glad, Alexander, that you have described some project of patient-centered project that gives some hope to you that things can go better. Unfortunately, in Slovenia, I don't see at the moment a similar project that would do this, that we know it's so important to work on relationship, on continuity, to include patient values, to make patient a source of control, to empower client to actively participate, to go to the direction of shared knowledge, transparency, and so on. Unfortunately, this is not happening in Slovenia. But we still are trying, at least in this small project of our outpatient clinic, to go in this direction. I hope I was half an hour, I think it was exact.
Thank you. Thank you so much, Miran, for your interesting presentation. I think it's very instructive to observe an healthcare system there, which is now growing fastly and trying to navigate the complexity. So it's very instructive in my opinion. So now we have time for some questions. I just checked the chat if there is some written question, but we are not so many, so we can just start an open discussion if you prefer.
Perhaps I would like to add that I just find an article that is quite coming in the author is thinking the same direction as myself, that there is a close connection between now this stage of capitalistic thinking, this neoliberalism and biomedical model, this goes very well together, and this is destroying the this collaboration and the networks that were efficient for many years. Unfortunately, this is like a cancer, and I think we must go very deep to the crisis, perhaps to rise again.
I have a question for you, Mira. How are you managing the connection between primary care and mental health? Do you have some specific professionals who operates next to general practitioners, or general practitioners are just referring to mental health professionals?
You can imagine what is the situation of primary health, especially general practitioners or family doctors. 140,000 Slovenians don't have access. They don't have their own doctor. In the past, that one GP had around 1,000 patients, 1,000 people to care. And now these GPs who are working in the system are overburdened. It's incredible. They have 5-10 minutes per patient. Blount has shown that it is possible also in a such frame to help people, but our family doctors are not trained in this way. So there are diagnosing very fast, especially mental health problems. We have now over-diagnosing problem with especially major depression, anxiety disorders are over-diagnosed. Attention deficit hyperactivity disorder is now expansion. It's diagnosis that people get it very quickly. Children, adolescents, adults, incredible. So and then GPs have instructions. They must offer very quickly medicines, but also people expect, now this is a vicious circle, a closed circle, that people expect medicines, and the GPs think they are obliged to give people at least some medicines. And the situation is really crazy. We have statistics. I'm not talking, I didn't show you the statistics of our National Health Institute, which counts every drugs that is prescribed, how many people get it. It's exponential, rising during the last 20 years, especially for children, adolescents, the use of antidepressants and other medicines is rising exponentially. Crazy, it's crazy.
I have to add that everything that Niran has talked about happens in the US as well. I don't want to portray the US as having somehow gotten over all of the struggles. When I talked about exemplars, I wanted to assert that they are there and that they are available to be learned from, and to describe what might go into making those exemplars and other exemplars. But I was not describing the system as a whole, I'm sorry to say.
Okay.
Yeah.
Is there any question
Especially
from the audience?
you talk, you talked about complex patients, that the term of the medical system, and this closely disadvantaged and bad prognosis patients.
Gunther, could you please stay closer to the microphone?
Okay, okay. Can you hear me now better?
Yes, better.
My question refers to the term of complex patients in the medical system, which means, as you told us, disadvantaged and bad prognosis patients. You are a society in complexity systems, complex systems, nonlinear dynamics. And could it be useful to take this term of complex patients more verbal, more concrete? This means you have methods in the monitoring of change processes which can measure and define complexity and change in complexity directly related to second order change of Bateson. And this could be a scientifically founded interpretation of change in complexity. In our experience and with the results of user surveys, we see that this monitoring of complexity should be very helpful, and patients perceive it very helpful. And this could be a contribution to the development of primary care systems. I think this would be an empirically evidence-based practice in your terms.
I'm not sure I'm going to be addressing what you said specifically because I wasn't able to parse it clearly, but it does remind me that if you saw my notes, when I talked about complex patients, it was in quotation marks.
Yes, I know.
It was not related to any careful theory of complexity. It was the medical system's name that essentially means we don't know what to do with these people, rather than based on a theory of complexity that might be used in other kinds of systems. So while I was trying to use Bateson's ideas as rigorously as I could, I'm highlighting the American use of the word complex to describe patients as, if anything, sloppy or possibly better served by other terms.
Mm-hmm. Yes, I understood, but I think the experience now and the good practice is monitoring change in primary care by systems which can continuously and in real time assess the dynamic complexity of change processes.
Yes.
And you can refer to this together with your patient. You can reflect on this data, based on data, and this in a real verbal term includes what you mean by empowerment in your team model and by mutuality in your team model. So you have a data-based interpretation of complexity in each case, and in each change dynamics. And this, I think this is at the moment the state of the art.
With this, in this respect, Gunther, I can say that one of the forthcoming webinars of the year will be about wearable instruments, and maybe it is something in that direction.
Okay, thank you.
Monitoring.
No, I appreciate the opportunity to say it. And I found putting this together to be something that allowed me to think about my own work a bit differently, to get out of a totally medical and mental health head, and to get back to my roots, to my dissertation on Gregory Bateson, and to my 20 years as a systems-oriented family therapist in mental health before I got into primary care. And it was very enjoyable. I really appreciated the process.
Thank you. We will keep you informed about our next webinars, and thank you for your presence, and thank you, Mira, Alexander, Gunther, and all the participants.